I'm Carole Taylor. On this edition of Journal, Dr. Julian Somers joins me to examine the need for a province-wide plan to support those with complex co-occurring disorders, CCDs. This refers to those individuals with substance abuse and mental disorders all at the same time. The care required is complicated, involving medical, psychiatric, housing, social, and legal issues, according to a paper co-written by Dr. Somers. Mayor Ken Sim of Vancouver shocked many of us when he announced the city would no longer permit net new supportive housing. On the surface, this seems crazy when we see the homelessness on our streets, the criminality, the crying need for mental health support. How could we say no to more supportive housing? However, surprisingly to me, Dr. Somers sent a letter of support to the mayor, complimenting him on this initiative to put the brakes on more supportive housing in Vancouver. As a licensed clinical psychologist specializing in addiction who has worked in this field for 37 years, one would expect him to say, "Give us as much supportive housing as you can." His perspective on what we are doing wrong is illuminating. Why are we concentrating so much of our support systems and services in the Downtown Eastside of Vancouver? Why are rural areas so underserviced that people feel they've just got to come to Vancouver to get help? Why do we see crime and violence increasing in these areas rather than decreasing despite the concentration of services? Perhaps, are we offering the wrong kind of support in the wrong places? Dr. Julian Somers joins me to discuss his proposed solutions right after this break. Dr. Julian Somers joins us to talk about something that he has been researching and working on for many decades, and that's supportive housing. And I think the fact that you started off working at Riverview is an important part of this conversation as we get towards where you are today. But when you were at Riverview, what was the reason for closing down Riverview, and did you support it?
Thank you. The way it was explained to me by my boss at the time is that not only here in BC, but around the world, jurisdictions were moving away from large institutions, so-called mental institutions, and shifting toward community-based supports for people. This was due to a variety of things, including in the 80s, the then recent advent of certain types of drugs. But more importantly was the fact that the long-term perspective for people who had what we considered serious mental illness was likely to include some attenuation of symptoms, even improvement, even remission. And the likelihood of improvement was much greater if people were preserved in the community settings that they were familiar with, where they were close to family, friends, all the other things that we tend to associate with community life, parks, the outdoors, that kind of thing. And so, and it was less expensive to do that and in people's best interests. So we were shifting to what was referred to as a community-based approach and a recovery-oriented approach, again, with that long term in mind. And so some jurisdictions made that transition more effectively than others. Here in BC, we have not done a very good job at all.
Yeah, what happened?
Well, the fears of many people that we, in the absence of building out the alternative, building out community-based forms of support, which had been clearly identified and described, that we would, as a result of that, be risking, by implication, herding people who have serious mental illnesses and no support into settings where they're essentially struggling to survive. And we see that now in places like, well, not only British Columbia, up and down the West Coast and in a great many places around the world, we see that the absence of those community-based resources that any substantial community needs results in people becoming socially isolated, and often socially isolated together because that's the forms of support that are available to them are termed various things, low barrier. One of the areas that I worked in, harm reduction. has become more or less synonymous with the lion's share of supports for people struggling with mental illnesses, often including addictions, and who don't have other forms of support to look after them.
So I think you're saying that the idea initially in saying we don't need Riverview anymore was because there were examples. If you could have the care in your own community, you had a better chance of recovery. But without those centers of care around the province, they end up wandering to the Downtown Eastside. And now we've got a concentration, certainly of services, but also of all these individuals that really need help.
Yes.
It's not working.
It's clearly not working. And the narrative I summarized is well documented now, empirically. So, for example, my team and people I've worked with have published, so all this is in the public domain in the scientific literature, evidence of where around BC are there communities with high concentrations of people who have been diagnosed with mental illnesses and addictions and who have been psychiatrically hospitalized 10 or so times, convicted of crimes 10 or so times, dependent on emergency shelter supports, and on an ongoing basis for years at a time. And what happens when we don't provide those supports? Well, in other publications, we've shown that the people who wind up in air quotes, hardest to house in Vancouver's downtown east side began having their problems outside the metro region, not even in Vancouver proper, but outside metro, 85%. And year, over the 10 years prior to our meeting them in the downtown east side, their problems worsened each year in aggregate, numbers of criminal convictions, numbers of months they were requiring financial assistance, numbers of hospitalizations, and it's taking, of course, an immense toll on them personally while they're going through this process of migration, pushed from places where their problems originate and drawn to places where they perceive or believe that there is a greater chance of receiving support. That winds up being places like the downtown east side.
And it really is around the province. I've seen some of your statistics looking at all, whether it's Prince George or Port Alberni, wherever it was, the number of people with these co-occurring disorders.
Yes.
Really, they're huge numbers, but they haven't got the medical or mental health support.
No, they don't. And that work, by the way, that you referenced came out, I think, in 2016, 2017. It was shortly after that, right around the same time that the public health emergency was declared. Our concern was that the people who are already in that kind of revolving door in communities around BC where they're not getting supports, all the supports they're getting are essentially emergency type supports, that those would be the very communities hardest hit by poisonings. And so a fateful request, I guess, on my part, turned out to be to request access to additional data, basically poisoning data, to see if that hypothesis would be borne out. And to this day, we don't know the answer to this question because we were repeatedly stymied and eventually ordered to destroy our whole database, partially due to this persistence. But now I think many people may not need that evidence any longer to be convinced that if you have communities where you know there are people struggling in the ways that you described, and we added dramatically more increased potency to the drug supply, that those individuals who already have a tenuous relationship with their own futures, their will to go on is weak. Those are the people who we're putting at greatest risk. And indeed, in some cases, we see the highest rates of poisoning now are in the same communities that we had identified as having the highest prevalence rates of people struggling with these concurrent disorders. We could have acted much sooner and more effectively.
Well, it doesn't seem as though we've acted in the right direction, and I do wonder how you turn things around. You presented a plan to the provincial government in 2021, I believe, that was a plan of how we could go forward and improve this situation. Can you describe the basics of it?
Let me make sure not to forget to alert people to the fact that it's online, Call to Action for BC, and if you look up SFU and Call to Action, you'll likely find it. That was an effort that came out of over a decade of research involving, and supporters of that plan included 12 of our leading not-for-profit societies. Their CEOs took the plan to their boards, and it was calling for, I'll use the phrase paradigm shift, just a different way of operating, decentralizing resources that had been shown to be effective in randomized controlled trials, trials conducted here in Vancouver, and implementing that same model of service in the communities where we had shown the highest prevalence rates of need were. And we had, in some cases, Indigenous specific services, but about 75% of them, this is more or less following the demographics of complex homelessness, about 75% of them were for any ethnicity. And the evidence that went into all of this included not only some of the findings that we've already referred to, evidence of need, evidence of migration. There had been randomized trials comparing current services with these preferred services, showing that crime and medical emergencies both were reduced by more than half in the first year. And perhaps for some decision makers, importantly, they cost the same. So usual care and the service model we were recommending and tested cost about the same in the first year. So we presented that to Mr. Eby, who at the time was not yet Premier. He was both in the role of AG and Housing Minister. And I've spoken to Mr. Eby a few times prior to that. This was the last time we had an exchange. And his last word to me after I presented this plan was, "Oh." And that was it.
No questions about it? Or
No questions, not even the customary staff will look at it and get back to you. Nothing. So fully budgeted, by the way, like a completely fully budgeted plan to scale up a different way of doing things.
We're going to continue this difficult discussion right after this break. We're joined by Dr. Julian Somers. And Julian, if I caught what you said correctly, I think you said the government got you to destroy your data and your research?
Yes. Yeah.
How can that be?
The saying that all that's required for evil to thrive is for good people to say nothing comes to mind. So for people to understand what I'm referring to here, over about 2.5 decades, my lab, many people working with me, international scholars, trainees here, developed a database of findings, the findings that we had used for our publications and data that we would use to add additional new material to in order to produce new knowledge. And the government in my view, did not want us to continue with that activity. And the evidence that I have is that I made a detailed presentation to BC deputy ministers, which I get to do once about every decade, and disclosed what our current plans were, what we had shown, and what we were planning to do. And 1 week later, our university received a letter from the BC government ordering us to immediately, and this is within the next 3 weeks, destroy everything, sanitize hard drives, and that was basically it. They didn't actually have the authority to control, really, I don't think any of this data, but certainly not data from randomized trials funded by the federal government and other sources of data that were really not related to the BC government. So I have to speculate about what their motives were. The timing is certainly suspicious, but the way it could occur is that members of my own university didn't have my back. They didn't come to my defense. And one of the things that senior administrators told me to try and explain this is that the discussions about the SFU medical school were in a delicate place and involved the same people that would need to be brought into a discussion about what's up with this order to destroy decades of data. So they did nothing. And these are the good people I'm alluding to in that comment earlier that really felt that they were powerless to, or that they didn't want to take a hard stand and risk creating conflict.
You know what's interesting to me is that you weren't recommending extreme, strange things. You're just saying, can we get care for those with drug abuse issues, mental health issues, closer to where they live? Like that,
yeah.
That doesn't seem threatening to me.
It is threatening, though, if the mainstream that I believe I'm representing, standing on the shoulders of my mentors and teachers and people that have made recommendations, Senator Kirby in his large report. I think that articulating that position is threatening if the alternative that the government is envisioning is frankly crazy. Then it's threatening. And I'm using hard terms now because if we look back 8 or so years, there was a distinct push that's on the record advocating forcefully that decriminalizing drugs and implementing a so-called safe supply was the main thing that was going to address this crisis. And now we can see in 2025, not so much. But at the time, there was really very little uncertainty in government that this is what should be done, and it must be fast-tracked, and we must eliminate any forms of distraction, such as me.
So starting from today, we've got this terrible concentration that's happened with all of the attending problems. What would you take as a first step? Because when I look at it, you can't say, oh, well, immediately all these wonderful cities around the province will have all this care in place. So what would be a first step? Would you maybe identify a couple of regional centers and start to put services there?
In many ways, my thoughts now and my recommendation would be very closely related to the call to action, which itself was a scaling up of services. It wasn't an all-at-once thing. The good news in BC is that we have a lot of human resources that are quite capable and even motivated to move into directions of providing better and more effective supports for people around BC. And this is our not-for-profit sector. It's also family physicians around BC, judges, police chiefs, notably, prior to decrim and safe supply, Canadian chiefs, BC chiefs, each issued reports saying we can get behind this as long as resources are implemented in all BC communities. This is from the BC Chiefs report. Resources are implemented in all BC communities where there's need before decrim goes into effect, right? So there were clear signs of support for evolving in a better direction. And I guess what I'm trying to emphasize now is we have the capacity. It doesn't cost more. It doesn't require different people than the ones that are already interfacing with those that are struggling the most. So yes, the way you began is my advice. Look at the places that are most readily poised to shift in the form of practice that some of them actually know about. They've studied it, they're aware of this work, they're aware that they're being forced to provide compromised forms of services. And start there, develop communities of practice. For heaven's sake, reinstate some of the information systems that we have established in BC. They're some of the best in the world. And use those in order to confirm that we're placing better services in the communities with the greatest need, and that we're transparently evaluating our outcomes. There should be no shame with being, slightly less well-performing than some other community. We can learn from each other and learn from this type of evidence. So those are some of the details in the call to action. I'd alter it now. We have more people with brain injuries, cognitive damage due to drugs and being multiply resuscitated. So, we have to change some of the characteristics of supports. But in broad strokes, the plan that we recommended in 2021, I think, is still a sensible starting point.
And so that was the basis for your sending a letter of support to Mayor Sims.
It was.
And what do you think is going to happen with his stand?
Well, it's a tough stand. I've come to learn that my common sense view that the mayor of Vancouver, the mayor of Victoria, shouldn't be enabling problems that really derive from deficiencies at the provincial level, and to a lesser extent federally. But most of the deficiencies, most of the things we could modify and do better are under provincial authority. So, but I learned, that very few mayors were willing to push back. I talked to Mayor Stewart, who of course was Mayor Sims' predecessor, and his position, this is in an open hearing, was that, well, if we say no to this low barrier project, the government's going to take away the money. So isn't something better than nothing? And actually my answer was no, it's not. But just it underscored to me the difficulty. So when Mayor Sim came out and said, look, we're going to stop enabling the concentration of low barrier services in Vancouver, which are really responding to a province-wide problem, I said, yeah, that's actually a well-supported position for the mayor to take. It's not the answer. He can point out how policies that are being forced on Vancouver are contributing to a broader set of problems. He doesn't have the authority to turn things around. So it raises, it maybe provokes a conversation between Mayor Sim, hopefully other mayors, and the province to look at an alternative way of doing things that better balances the implementation of resources so that they fit the needs in all of their communities.
It just makes me feel that we never learn from our mistakes. I mean, Riverview, we'll just do away with Riverview, send everybody home with a bus. Here's your bus ticket, off you go. And because the supports weren't there, we've ended up with these incredible issues. And now we're still in this situation. Concentration's there. Well, we're not doing anything that's province-wide that says we all have to participate in this.
Yeah, it's
leadership.
Leadership, courage to spend differently. That seems to be a big one because it's not about spending more. In fact, providing care more effectively would, I believe, it should be expected to lower public spending.
And so now we get into the health authorities and trying to get them to move and change. We will do that another day.
Okay.
Thank you, Julian, for being with us.
It's such a pleasure, Carole. Thank you.
We'll be back in just a moment. Dr. Somers' findings demonstrate that individuals with complex, co-occurring disorders live throughout the province, in Prince George, Port Alberni, Kamloops, and elsewhere. Research also shows they have a better path to health and recovery if they can be cared for in their home community. But these municipalities are not receiving the support and health services they need to care for them. Let me know your thoughts on YouTube. Till next time, I'm Carole Taylor.